Good morning, everyone. My name is Elizabeth Harris, and today I'll be talking to you about Module 6, Culture and Health. Here are the learning objectives for this session. You should remember that these objectives are linked into the quiz at the end, so there is a link between these objectives and the quiz. So why is culture important in the role of the patient navigator? For you who are working in the community, you will know that 20% of the people that you come in touch with will speak in a language other than English at home, and 30% of the population will be born overseas, and half of the people that you deal with have at least one parent who was born overseas. Language and culture affect health and access to health care. For example, people from some backgrounds are unused to dealing with mental health problems and may react negatively to any suggestion that they may need counselling or access to psychologists or psychiatrists. The health system in our work as cultural mediators, cultural navigators, cultural mediation will be very important. And this is really establishing a dialogue between people of different cultures to make sure that they can have access to the services they want. It is very important that we understand cultural mediation and the roles of the navigators as a two-way process, with patients and communities sharing their skill and understanding with the health service, and vice versa. This can include your role as a navigator being able to recognise and addressing perceived barriers to care. For example, some cultures do not like male doctors examining their womenfolk. It might be educating your individuals and communities about how to use health and social services. This has been very important in the COVID epidemic in explaining the importance of contact tracing and also immunisation. We can also have an important role in educating the people you're dealing with about the needs of people in the community. And this may be addressed through education, better use of interpreters, and referral to specialist services who have in-depth knowledge about the problems of migrant communities. Cultural competence is a common approach to dealing with these issues in the health system. And especially with Aboriginal people, there has been a requirement across many local health districts that all staff should be trained in cultural competence. Cultural competence is the ability to understand, communicate and interact with people of different cultures. It tends to focusing on what people should and should not do. Often this is turned into a checklist of values, beliefs and skills that can be mastered. Sometimes this can be seen as a static process that results in stereotyping of particular groups. For example, all Chinese have high aspirations for their children's education. Another approach, and one that is becoming increasingly important, is cultural humility. And this starts on the premise that healthcare providers are not always experts or have the knowledge of the perspectives of migrant communities on issues that their patients are experiencing. As I mentioned before, cultural humility is a two-way process that recognises that the patient may be the expert or actually is the expert on their own life and the problems that we face and that they are facing, and therefore should be taken very seriously. 3 ways of promoting cultural humility is to reflect on your own work. So to be critical, or at least think about what you've done and how it could be improved and what you need to learn. Recognise that the health system has a strong hierarchy and power structure, and often this means that services are not fairly distributed, or in fact that patient navigators are not treated with the due respect that they want. We may also, as bilingual navigators, have to act on behalf of our clients to see that the things that we feel need to be done are being done. For example, that when people need interpreters, that this is not seen as a negative, that the person who doesn't speak English is some way at fault, rather than that the health system may have to take responsibility for learning to speak to people in other languages. Another way that bilingual patient navigators can deal with people from migrant backgrounds who may be different from their own is by respect. And the slide shows you how this is constructed. Rapport, meaning that you try and understand the position that the patient is coming from. Empathy, to show an understanding of what emotions and issues they may have, to support them to understand their problem and what might be able to be done about it, not to work with them in partnership to try and solve the issues, and do this by trying to explain to them what the issues might be and how they can be addressed. And finally, to work within a framework of cultural humility, where you understand that the patient isn't experienced in their own problems in life, and that we should encourage our work to focus on these issues rather than only the issues the health system may have. For example, a hospital may be very keen to discharge a patient because they are very short of beds, but on the other hand, the patient may be very worried that they've got no one to look after them when they go home. And so through a dialogue between the health system and the patient, they may be able to reach a compromise. For example, having a health worker visit them or a nurse visit them a few times a week. The other thing, apart from respect, is to learn. So it's about listening. So one of the real skills of the navigator is to listen and try and understand how the patient sees the problem, and not just how the health service sees the problem. Explain to the patient what you think is the problem and what the health system sees as the problem, if these are different. Acknowledge that this will often require you to talk about the differences and similarities between your expectations, and recommend treatment and negotiate an agreement based on this treatment with the health services. Bias is another issue which is very important when you're dealing with migrant groups, and we may have conscious or unconscious biases. And what it means is that we have a prejudice against a particular group of people, or a group of people from an ethnic background or a part of an area, and it's usually framed in a way that is unfair. It may be conscious or unconscious. The first step in addressing bias is to bring it out into the open. This can be done through audits or analysis of activity. In my own experience of bias in working with unemployed people, we would, or any group of health workers, is that you can point out to them, not all people are being admitted to hospital in the home based on need, but maybe on their background. But people will say, no, that is not true. We treat everyone the same. And it's only when you can give them the information from their own work that shows that that's not true, that you can begin a discussion about how do you deal with bias. There are many language barriers that community health navigators will face, and we recognise that all workers will not be able to speak all languages. So how can you overcome some of these barriers? I think you routinely ask, what language does the patient speak or prefer to speak? Have signs in the waiting rooms in different languages. Have staff wear a button or tag that indicates what language they speak other than English. In their medical records to record the language that are preferred. And have forms that are translated into multiple languages, as well as health information, and to put as much of this online as possible to make sure that your service is registered with the telephone interpreter service. Now in this module we have two ways of assessing. One is the quiz, and the second is a workbook which you would be asked to work through and bring back to the face-to-face session that we will be having at the end of the course. Thank you. If you have any questions, feel free to contact me or Sabuj. Thank you again.